In the last video, we finished up our actual discussion of schizophrenia and all the different actual differentials you would have that can become very confusing and very conflicting at times, right? So we had our discussion about bipolar, where bipolar 1 is one thing. It needs to have mania, right? It might also have hypomanic and depressive episodes, but manic episodes are very necessary there. Bipolar 2 has two things. It has the hypomanic and depressive episodes, both. Right, but there has to be both things. You have to have hypomanic and depressive, and there has to be no manic episodes there, right? Because manic episodes define bipolar 1. We talked about schizoaffective, schizophrenia. We mentioned major depressive disorder, and then the concept of MDD with psychotic features. There was also a practice question we did from UWorld up here about bipolar 1 with psychotic features, right? So there's a lot of things here, and honestly, no matter how much you really study it at first, it's still possible to look at a question and fully convince yourself that it's actually something else than whatever the correct answer is, right? So you can see a question and you might think that it's actually schizoaffective when it might really just be bipolar 2. Or you might see a question and think it's MDD with psychotic features when it's really just schizophrenia. So it's very important to be able to understand the major differences. So I have some images today that I wanted to kind of share and a general summary of everything we've done so far in psychiatry. So right here I wrote schizophrenia, right? That involves just three things. It's schizophrenia, which is more than 6 months of having positive and negative symptoms, right? So hearing voices, seeing things, right? Those positive symptoms are the actual defining feature of schizophrenia. Brief psychotic disorder is basically the same thing that lasts less than a month, and schizophrenic form is between 1 to 6 months. They're just time differentials of schizophrenia. Schizoaffective, though, is a whole different thing. Schizoaffective has affect in it, which is, from affection. So affective means that there's going to be a concept of mood disorders there, right? So schizoaffective is going to have mood disorders plus psychosis, both things. And the psychosis can occur individually, which means that the psychosis and the mood disorders don't always occur together. And when we say mood disorder means anything. It can be manic, it can be hypomanic, it can be just depression, right? Any of that. So when we looked at schizoaffective, right, it straight up says share symptoms with both schizophrenia and mood disorders, major depressive or bipolar, right? So you can have symptoms of bipolar disorder and have depression, right? And have psychosis all at different times. When you have them all at different times, that is schizoaffective, right? And this is one of the most confusing things at first because it's really hard to differentiate schizoaffective from bipolar 1 or bipolar 2 in the beginning when you just started studying, right? So this timeline over here kind of helps you differentiate schizoaffective disorder versus major depressive disorder with psychosis versus bipolar 1 with psychosis, right? These are the ones that become very confusing because bipolar 1 is easy to understand. It's literally just mania. There's nothing else. You might have depressive episodes or, they put it here, manic plus or minus hypomanic or depressive episode, right? But the manic episode is the defining feature of bipolar 1. So you could have other things, but then when you look at bipolar 1 with psychosis, you're thinking, oh, so you have mania and you have psychosis. That sounds a lot like schizoaffective, right? So here, this timeline and the color coding here really does a brilliant job at giving you good study material, basically, to get the differentials down effectively, right? So the main thing here, if you look at schizoaffective disorder, right, you have the purple area and then you have the blue area. So what you're seeing is that the mood, right, the mood symptoms, which are the purple, mostly overlap with psychosis. Okay, so you can see the purple is the psychosis, the mood is the blue triangle. All of these triangles are mood symptoms. Okay, so this is a diagram that's coming from USMLE RX when the guy was describing whatever's happening. So if you want to see the actual video, if you have USMLE RX, you can go ahead and look at their psychiatry video. So the triangles here, they're pointing up or down based off of the mood, right? So that's why it's a triangle. And these pyramids over here, these are your psychosis. So you can see in schizoaffective, you can have psychosis with no mood. And then you can have mood, and those mood symptoms, usually you see the red line here, they usually overlap psychosis. What you don't have in schizoaffective disorder is strictly mood symptoms with no psychosis, right? It's not happening. You don't have strict mood symptoms that do not overlap with psychosis. So all in all, you can have psychosis occurring alone, but every time there's a mood symptom, there's also psychosis. Okay, so that's what really helps you understand schizoaffective. You have to have a mood disorder, bipolar, or depression, and you have to have psychosis. And the psychosis is the only thing that can occur individually. That's why I wrote that here. Psychosis can occur individually, alone. That's the red line right here. So let me write that into the picture too. This is the period of, oh, that's too big. So that purple area is the period of psychosis right there. Right, so. But you can see that the blue area, where you have your down mood, the down mood over here, this mood is overlapping with the psychosis. So you can never pick schizoaffective as an answer choice if you're seeing that there are mood symptoms with no psychosis, right? That doesn't happen because then it's a different answer choice. So now we look at major depressive disorder with psychosis. Remember from yesterday that major depressive disorder required 5 or more of these 9 SIG CAPS things, in which at least one of the things have to be reported by the patient himself, such as him saying him or her saying that they have a depressed mood, or they have anhedonia, right? Loss of interest in things they used to enjoy. Like maybe they liked going out for game night or something, and now they don't do that. They like playing, video games online, and now they don't do that. Something like that. Okay. So major depressive disorder would be SIG CAPS, 5 or more of those symptoms, and then if you have MDD with psychosis, right? So this is what they're showing here. They're showing psychosis only occurs with mood, generally at a TRO. So you can see this darker triangle down here. Right, the standard blue triangle was just a mood, and the mood was overlapping with the purple psychosis. Here what they're showing you is that the psychosis and the mood both occur together, and it's always a sad mood, because this is depressive disorder, right? So you have your depressed mood with the psychosis occurring together, then you pick MDD with psychosis. And we saw that yesterday too. We read MDD with psychotic features over here. And they tell you psychotic features are typically mood congruent, which means that the mood of this patient is depressed. So all those psychotic features go with the sad mood, right? And those sad congruent things are going to be like thoughts of nihilism, disease, death, punishment, guilt, right? These kinds of psychotic thinking. And those psychotic features occur only in the context of major depression, right? Whereas in schizoaffective, which we just talked about, right, versus schizoaffective, in schizoaffective, you can have psychosis with no mood symptoms. Okay, so that's the big difference there. And then you look at bipolar, right? So bipolar 1, you have to have manic episodes. You might also have hypomanic or depressive episodes, but you have to have manic episodes. As soon as you see manic episodes, you start thinking bipolar 1, and then you read more of the question. Might have psychosis concurrently with the mania, but never individually. Okay, that's bipolar 1. However, if you have bipolar 1 with psychosis, the psychosis only occurs with mood, generally at a peak, which is different from major depressive disorder with psychosis, right? MDD with psychosis, your psychosis occurs at the TRO, at the bad, low mood. Bipolar 1 with psychosis, the psychosis here, the darker orange up here, is occurring with the positive high mood, right? Because these guys they have that manic episode, and the psychosis is with the manic episode. And remember, mania is the exact opposite of depression. In mania, you have excessive energy, you don't need much sleep, you can do everything you need to do, you'll achieve all your goals, and these guys usually have very absurd goals, like gaining world peace or killing some kind of major president, something crazy like that. And those concepts of understanding how mood is presenting and when the psychosis is occurring is what really makes you very good at psychiatry, basically, right? So if your goal is to match in psychiatry one day, then this is going to be something that you're going to have to be very, very good at, right? Because that's what patients are going to come and tell you. And when you look at their history, that's what you're really going to have to understand. So when you get a question, and we've done a lot of questions already, right? We did all of these in yesterday's videos. The video before that, we did this entire page of questions, right? Where I gave you the explanations. I explained what happened. You read the question with me. and then we discussed why the answer was what it was. And what we saw was that a grand portion of people were getting it wrong, right? Like this first one, the correct answer was schizophrenia. 21% chose MDD with psychotic symptoms, right? But remember, MDD with psychotic symptoms, the depression and the psychosis occur together, right? Depression and psychosis occur together. And that wasn't the case for this patient. Here at the bottom over here, right, the correct answer was schizoaffective. Only 33% got it right. 43% actually just went with schizophrenia. Right? Another big disruption right there, right? And even this question here, only 25% of people chose correctly and said it's schizoaffective. 66% chose either bipolar disorder or bipolar disorder with psychotic features or schizophrenia. Right, 33 each. That was a really big disruption there. But it's not that it was that difficult. It just takes actual integrity and actual good grasp of the information to be able to make that difference, right? To be able to catch that differential between patients. So when you're doing psychiatry, when you're studying this, it's very important to make sure that you understand this timeline of when things are presenting, right? And then be able to see that in all the practice questions you do. Right, so when you do a psychiatry question, what I like to do is I actually like to make something like this, right? It's actually very helpful. So when you're doing a psychiatry question, you always have scrap paper, or you could do it anywhere, even on the actual screen that you're doing your question on. Basically, when you're reading the question, you really want to just make a line like they have here, right? And then come up with your own kind of legend, right? So for example, if you put an X for you, that might mean psychosis. And if you put a check mark, right, or a V, this looks like a V now, but it's supposed to be a check mark. Like if you put a check mark, those are going to be your mood symptoms, right? And then as you're solving the question, put those marks. So you might read the question, they might tell you, oh, 3 months ago, this patient had some kind of mood symptom. So in the past, he had a mood symptom. Today, he's presenting with psychosis and a mood symptom. Okay, so you got that and the X, right? So now you can see this looks a lot like the first one, that's schizoaffective disorder. Okay, mood and psychosis occurring together, but sometimes you have just psychosis, that's going to be schizoaffective. Here, I think I was saying this is mood, right? And this is psychosis, so that's going to be a different thing then. Right now, if you have mood symptoms that occur alone, right? If you have mood symptoms that occur alone, and you have psychosis that always occurs with mood, now you're looking at bipolar 1 with psychosis. So making a legend for yourself and actually using it in questions correctly and practicing using that timeline method in the questions you do is going to be very critical. It'll help you really be able to see the answer rather than have to keep rereading the question. It takes up a lot of time if you waste time actually rereading the question over and over, especially because a lot of these psychiatry questions on step 1 are going to have tons of extra information, weird history, excessive information about other things that you don't really need to be able to evaluate the diagnosis there. Right, so come up with a legend for yourself, use circles and triangles, use whatever you have to use, and make a line like this, right, a timeline, so that when you're reading a question, you can actually effectively mark down what kind of symptoms presented, right? And then based off of that, whatever you see gives you the answer, right? So if you want, you can actually use the same thing here. The only issue with this one is what they used was actually color-coded, so it makes it a little difficult for you to use this. For example, here, right, it's just a triangle, but it's the color that's telling you what actually happened, right? This is a high mood with the psychosis, whereas here, this is a low mood with psychosis. And you can see that the direction of the mood was actually important because you have a low mood with psychosis, that's MDD with psychosis. If you have a high mood with psychosis, that's bipolar 1 with psychosis, right? Otherwise, if you have mood and psychosis, but then you also have just psychosis alone, that's schizoaffective, right? Here in bipolar 1, the only thing you have alone is mood, but no psychosis occurring alone. Right, very big thing to be able to catch the differences of, and you have to practice that. So now another way that these things get described is something like this, right? So psychiatry is not famous for graphs and stuff, right? But on your step 1, it can be, right? And on your NBME, it definitely can be. So what we're looking at here, although initially might look a little intimidating, it's actually not that bad at all. So this is an explanation from osmosis where they did this, right? This is the kind of diagrams they make in osmosis. So they're comparing normal depression, unipolar depression, Then is bipolar 1 and bipolar 2 and cyclothymia, right? Remember, cyclothymia is like bipolar, but very, very long term, right? So over 2 years of being bipolar. It's usually less extreme, but just because it's less extreme, so the heights get lower, but it's very, very long term. So you can kind of see, if we follow each one by one. But the first thing I want to look at is the average person, right? The average person also has moods, right, that go up and down, and it's perfectly normal to have high moods, and then you have low moods, right? Some days you're just not that happy for whatever reason, and that's the normal trajectory, that projection that we're kind of seeing that with the green one. So that's pretty much any average human. Then you have unipolar depression, which is in the blue here. So you can see the blue line goes like this, follows the average person, but then the lower mood is very low. You see? Extremely. It went so much further down than the average human, and then it came back up to being, average high. So the main takeaway from the blue line is that the high moods are never that high, right? But the low moods are significantly low, right? The high moods don't even get as high as the average human. The average human was having higher happy moods than the depressed person. So that's your major depression. Bipolar 1 is this lighter pink. So you can see it starts off with a very, very, very low mood, and then it alternates into a very, very, very high mood, and that's what defines bipolar 1, right? Bipolar 1 is defined by this significantly high mood of mania, right? That's what defines it. But again, remember, in bipolar 1, you can also have hypomania, and you can also have depression. But the defining feature for bipolar 1 was the fact that it reached all the way up here to mania. The next thing is bipolar 2, which is this darker purple. I do wish they used a completely different colors, but you can still see it. So the darker purple follows bipolar 1 in terms of depression, right? But then the coming back up, it only reaches up to here, the hypomania, right? Bipolar 2 does not have mania. So they will have hypomanic episodes where they have unlimited energy, juggling multiple jobs, taking care of multiple issues at the same time, barely sleeping but still being fully rested, something like that. And that alternating with really, really low moods, that's your bipolar 2 right there. Cyclothymia, you can see, is the really dark one, which alternates between a midway low and a midway high of moods, really just cycling. But it's not as extreme. The lows are not as extreme, and the high only goes up to regular hypomania. Okay, so this graph does a basic job of just kind of showing you the ups and downs. But the real thing that you want to develop for tackling psychiatry questions, especially if you're having trouble with it, is coming up with a legend for yourself, most likely probably by using circles and triangles, where the triangle should be for the mood disorder, right? So if you have a triangle pointing up, it'll be pointing to a positive mood, and if the triangle is pointing down, it'll be towards a depressed mood. Anywhere you put a circle will mean that that patient had psychosis, right? And what you're going to, after you transcribe the question into a timeline, you could just look at the timeline now and understand that if you see any individual circles, which define psychosis occurring alone, that goes into schizoaffective, right? But if you see every mood has a psychosis to it, that goes into one of these guys based off of what kind of mood it is. If it's a depressed mood with psychosis, that's MDD with psychosis. If it's the happy moods, the really, really manic or hypomanic moods that have psychosis, then you go with bipolar 1 with psychosis. Bipolar 2 with psychosis is almost never really an answer. I've never seen that occur as a answer choice per se, so don't worry about that part. Okay, so that was all the stuff we did yesterday. I have some extra white space here, so I might find more questions later, put them here, maybe do some practice questions where I show you how to use the timeline so that you can also start applying it. But you should really try learning how to do the timeline by yourself, because then it becomes more personal to you, and it's not something that you'll be memorizing. It'll actually be something that you'll be tailoring for yourself. All right. So that's everything that we've covered so far in psychiatry, right? We got the ego defenses down. Got to review that one more time if you don't remember them very well. We finished up schizophrenia. We finished up basic mood disorders, right? And we looked at delirium, dementia, all of that stuff. Now we're going into a different set of things that are a little easier than all the actual psychosis and psychiatry related topics. So next thing here, peripartum mood disturbances, right? So peripartum mood disturbances, onset during pregnancy or within 4 weeks of delivery, increased risk with history of mood disorders. So if a patient had bipolar 1 before giving birth, right, or bipolar 2, if they had bipolar disorder before getting pregnant, you should think of two things. One, there's a high chance of them having peripartum mood disturbances during or after delivery. And two, think of the fact that they might have been using lithium or some kind of medication which could cause teratogenic effects. So keep that in mind as well as you read the question. It's always nice to be able to think of what's happening while you're reading a question rather than reading it blankly because you start falling asleep. So we have three partitions here. So maternal blues, MDD with peripartum onset, or postpartum psychosis. The most common is this one, postpartum blues, right? Maternal blues. 50 to 85% incidence rate, characterized by depressed affect, tearfulness, and fatigue starting 2 to 3 days after delivery. Usually resolves within 10 days. Treatment is supportive. Follow up to assess for possible MDD with peripartum onset. Now, one really important thing to catch here is the fact that you don't give any medications. There's no treatment necessary. Right? The treatment is just supportive, which really just means that, you know, if they give me a second. Okay, excuse me. A treatment being supportive really just means that you give them therapy if they need it, but you don't necessarily have to give any medications here. Okay, so that's almost never the answer. The correct answer might be something like follow up again very soon, like next week. Meet them again in another week. Make sure they're doing okay. These questions usually present with a mom that just has episodes of crying, right? But the differential is going to include things like, well, we're going to see it, but there's differentials that you have to use to be able to differentiate between these two things, like if the mother wants to hurt the baby, if the mother has any thoughts of suicide, stuff like that. But here you're just seeing, you see the mom is just sad. It's literally, the mom is just sad. Okay. MDD with peripartum onset, this is MDD, right? So now you're going to think of the 5 things from the SIG-ECAPS. 10 to 15% incidence rate, formerly known as postpartum depression, characterized by depressed affect, anxiety, and poor concentration for 2 or more weeks. And now you have to kick in the medications, right? Because if something like this is happening, if MDD is happening for 2 or more weeks, this actually makes a person very non-functional. If this mother has a job to go back to, she's not going to do a good job there. Okay, so now you can start the CBT, cognitive behavioral therapy, and put her on fluoxetine, sertraline, whatever SSRI necessary. Right. The really low incidence rate one, and the one that's really, really bad, is postpartum psychosis, characterized by mood congruent delusions, hallucinations, and thoughts of harming the baby or self. Okay, so these are the things you ask a patient when they come up presenting with what might be postpartum blues. Right? So if a mother comes in telling you, hey, I've just been randomly crying all the time, I feel tired all the time, she just gave birth like maybe 2 weeks ago, right? The delivery was 2 weeks ago. That means that it kind of might not have resolved in the 10 days. So now you ask the patient, what else are you feeling? Do you have any, are you seeing things? Are you hearing things? Are you having any of these psychotic symptoms, right? Delusions, hallucinations, thoughts of harming baby or self. These are all psychotic features. And then you have to check your timeline to make sure it's all mood congruent, which means every time she has that mood, she has those psychotic features. But never has psychotic features occurring alone. Remember, we just said from our previous timeline, when the psychotic features are occurring alone, which means for our timeline, it's a circle that's alone, that's schizoaffective, right? So that's not going to be a postpartum psychosis thing per se. All right. Risk factors here include history of bipolar or psychotic disorder, first pregnancy, family history, recent discontinuation of any psychotropic medication, right? Treatment is hospitalization and initiation of atypical antipsychotics. And if that doesn't work either, ECT may be used. Okay, but definitely the hospitalization part, because there is a risk of harming self or baby, so you don't want either of those things to happen. You don't want her to kill the baby, and you definitely don't want her to hurt herself either. All right, so very important to understand those differentials and make sure you understand the fact that there's no medications for the postpartum blues. It just usually resolves. The peripartum MDD, you give antidepressants, SSRIs. Postpartum psychosis, you give antipsychotics, right? It's pretty logical. It makes sense, straightforward stuff. Nothing too crazy. Here we're looking at the Kubler-Ross model of grief. right? The 5 stages of grief per the Kubler-Ross model are denial, anger, bargaining, depression, and acceptance. And these things may occur in any order. So the first thing a person might do is actually possible to just be acceptance. Accepting the fact that whatever's happening is happening, right? They don't have to show denial, anger, bargaining, and depression. They can just jump to acceptance too, so make sure you understand that. These things can occur in any order. Other normal grief symptoms include shock, guilt, sadness, anxiety, yearning, right? Shock and like guilt can be something like, oh, you know, this is probably happening because I did that thing 2 years ago, right? Now I'm being punished. You know, yearning, crying about it. And somatic symptoms, even that's normal, right? Somatic symptoms, they usually occur in waves. These are all normal grief symptoms, okay? Simple hallucinations of the deceased person are also common, right? So maybe they might say like, you know, the grief is often something that follows after a loved one or someone died, right? So you can have in normal grief thoughts of maybe hearing someone saying something, right? That's not psychosis. Don't fall for that. Any thoughts of dying are only limited to joining the deceased, right? So if a patient is claiming they're suicidal, but it's really not suicidality, it's more like them just saying they wish they were with that person too, that's different. That's still grief. Duration varies widely and usually self-resolves within the year. So as soon as you see a question that's lasting more than a year of grief, that's not good, right? So now you can see complicated grief is persistent and causes functional impairment, can meet criteria for MDD. So you're going to start seeing the CG caps things. And the timeline of more than a year, right? After a year. If grief lasts more than a year, that's not good. That's problematic. And if I make this image bigger, we can see the Kubler-Ross model here, right? So you can see your y-axis is your moral and competence. Okay, moral and competence, and this is your time on the x-axis. So you can see that moral, or your competence, your ability to actually take care of daily function, is going up and down based off of which mode you're in. Right? So shock, surprise or shock at the event that someone died. Let's say that this is the grief about someone's death. Denial, not wanting to believe that that person passed away. Frustration, mad that that person passed away and you couldn't do anything about it. You couldn't be there for them maybe, something like that. Being very depressed about it, right? Experiment, this is one that's pretty rare. So initial engagement with new situation. Decision, learning how to work in the new situation, right? Dealing with the fact that this person has passed away. It could be a mother, it could be a wife, it could be a husband, anything like that. And integration, changes integrated a renewed individual. Okay, so now you've accepted whatever is happening and you've gone ahead to manage however you have to without that person or without whatever you're grieving about being there. This is usually never a very complicated question, so it shouldn't be that bad. What they're going to try to convince you into thinking is that the person has schizophrenia or some kind of bipolar psychotic disorder, something like that. As long as things are normal, really understand what are normal things in grief, then you can just go ahead and be okay with that. All right, so all these things are normal. Simple hallucinations of the person are normal, and hearing things from the person saying something, that's normal. Thoughts of dying to join the person are normal. Other than that, if they're hearing or seeing things that are not related to the person at all, or if they just want to die because they just want to die for whatever other reason, that is not grief. So that's it for that. Electroconvulsive therapy. So ECT, rapid-acting method to treat resistant or refractory depression, depression with psychotic symptoms, catatonia, and acute suicidality. Induces tonic-clonic seizures while patient is under anesthesia and neuromuscular blockade. Right, so anesthesia and neuromuscular blockade are used so that you don't actually have the tonic part happening in your body. Adverse effects include disorientation, headache, partial anterograde retrograde amnesia, usually all resolving within 6 months. No absolute contraindications, which is something you really will have a difficult time convincing your patients of. And the best part is it's actually safe in pregnant and elderly individuals. Okay, so this is something that a lot of people are very quick to deny. They're not going to accept going through electroconvulsive therapy, but it's actually pretty safe, and anyone can get it done, right? There's no absolute contraindications. Anyone can get it done, so make sure that that's something that you do let your patients know about, especially if medications are not working. Now, risk factors for suicide completion. This is usually going to be a question where they'll tell you a patient is suicidal, and then they'll ask you which one of these answer choices increases the risk of them successfully committing suicide the most. Very important to understand that there's a difference between attempting suicide and actually succeeding, right? So the most common method in the US is firearms, right? Access to guns increases the risk of suicide completion. Women try more often, men succeed more often, right? So very important to understand that. Women will attempt suicide multiple times, whereas a man in their first attempt will probably end up actually dying. Other risk factors include recent psychiatric hospitalization and family history of completed suicide. A family history of completed suicide is a really big deal. If someone in someone's family was able to complete suicide, and maybe this person even knew that person, that further motivates them and inspires them, if anything, to be able to go ahead and commit suicide successfully. So, right, so risk factor is sad persons, right? There's a pretty nice mnemonic that it fits that way. So your gender, your age, whether or not you have depression, any previous attempts make, and they tell you here, highest risk factor, any previous attempts make your next attempt succeeding very, very likely. Right? So previous attempts are the highest risk factor for someone being able to complete suicide. Okay? Drug abuse, rational thinking, right, like psychosis. So if you have irrational thinking is what they're really saying. Any medical illness, an organized plan. This is something you always ask someone, right? In a psychiatry consult, one of the things you ask is, do you have any thoughts of suicide? And they might say yes. When they say yes, you ask them, do you have a plan of how you're going to do it? And they might say yes, and then you have to figure out what their plan is, and this might actually require hospitalization now. And then no social support, not having anyone. If you're a single individual living alone and you don't have anyone in this, state or whatever, then that also further improves your chances of succeeding suicide. And stated future intent. If you say you plan to commit suicide, same kind of thing. Right, so sad persons, this last one is not that important. You could just remember this as a sad person, one sad person, right? Because the organized plan is basically a stated future intent. The difference here is that a stated future intent is literally them saying it. In the consult, during the time within the clinical scenario, they might say, like, I'm just going to commit suicide Thursday, something like that. Right, so that pretty much tells you they most likely will do it. So you might need to hospitalize them. All right, so very, very nice list. Just remember, previous attempt is the highest risk factor. Having access to a gun is the other highest risk factor. They're both the highest risk factors. If they're both if you have both answer choices there, and a question asks you, what makes their chances of completing suicide the highest, I honestly can't tell you which one you would pick. So hopefully both things are not there, right? Because a previous attempt is the highest risk factor, and the ability to have access to a gun is also an extremely high risk factor. Both of them make your chances of completing suicide equally as high. All right. So I don't think both things will be an answer choice there, but if they are, read the question as many times as you can and really try to figure out if they tried giving you something in the question that helps you pick one answer over the other. Otherwise, good luck. Now, the next thing are your anxiety and panic disorders, right? So those are two more things that are pretty intense, very disturbing, right? The entire anxiety spectrum disorders. One thing you definitely want to understand is none of this has to do with psychosis, right? There is no psychosis in any of these disorders here. The anxiety spectrum disorders are going to have things that are more somatic, more physical, heart rate, sweating, stuff like that, right? Muscarinic things. So anxiety disorder, what's this about? Inappropriate experience of fear or worry and its physical manifestations incongruent with the magnitude of the stressor. Symptoms are not attributable to another psychiatric disorder, medical condition, or substance abuse. Includes panic disorder, phobia, GAD, and selective mutism. Right? So these are all things that are within your anxiety disorder, anxiety spectrum of disorders. Treatment for all of these, pretty much, you just give SSRIs or SNRIs. That's it. These are basically your antidepressant medications, right? So we can see this first question right here. 40-year-old woman, this is from UWorld, comes to the office due to persistent anxiety and insomnia over the past 6 months. She says, I'm really worried that something is wrong with me. I was never a particularly anxious person, but now I feel anxious all the time. Sometimes I feel panicky for no reason and have episodes in which my heart races and I break out in a sweat. The only benefit is that I have lost 5 pounds without even trying. The patient has no significant medical or psychiatric history and takes no medication other than an occasional alprazolam prescribed for insomnia by a previous doctor. The patient says it helps my anxiety a little but wears off quickly. Blood pressure is fine, pulse is 106. On physical exam, she is restless and has warm, moist skin and mild hand tremor bilaterally. Mental status exam is notable for a frightened appearance, anxious mood, and rapid speech. What is the most likely diagnosis? Now, with questions like this, right, because I just told you it's going to be more somatic symptoms and it's going to be very muscarinic stuff and things like that happening, answer choices often tend to include things like hyperthyroidism, pheochromocytoma, hypoglycemia. You have to make sure that the patient has some symptom that you would not see in just hyperthyroidism, in just hypoglycemia, right? Her symptoms, a lot of these things could be symptoms of hyperthyroidism, losing weight without really trying much, random moments of increased heart rate, sweating, right? These are all things that can occur in hyperthyroidism. They went on to really try hard to explain, right? Warm skin, moist skin, a lot of these things, right? But it was the other symptoms that she's having that really make this more than just a hyperthyroidism patient, right? So here the answer was anxiety due to a general medical condition. This patient, right, for our question, actually has some issue that is not just anxiety, right? I just told you guys I just said right now that make sure the patient doesn't have symptoms that don't fit just hyperthyroidism, right? But this patient, the way she's presenting, is actually having symptoms that are not just part of anxiety. Anxiety does not make you lose weight, generally speaking. Right? Her weight loss, despite normal appetite, tachycardia, warm skin, tremor, a frightened stare, which is possibly eyelid retraction, restlessness, and all of that are consistent with hyperthyroidism. When you were reading this question, it should have struck you a little. You should have possibly thought about the fact that this looks a lot like hyperthyroidism. Even though she's saying she's anxious, hyperthyroidism can make you feel pretty anxious, right? Because you have all that extra energy, you're going to be very, very, mobile and stuff. But her symptoms of a frightened stare, that was supposed to make you think of the Graves' ophthalmopathy, when the eyes stick out. And it should have been very evident when she lost weight. That's when, right? Losing weight usually in questions is about like cancer, right? Because of cachexia. But here, in this scenario, they're really trying to make you think of anxiety because, they keep talking about it. The first sentence even says it. Persistent anxiety and insomnia, right? Really worried, really anxious, blah, blah. But then all her symptoms are very somatic hyperthyroidism, okay? Other medical conditions known to present with anxiety includes hypoglycemia. When you have low sugar, you're going to have anxiety symptoms. Pheochromocytoma, the hypertension, right? Hypercortisol, and cardiac arrhythmias. Right, having palpitations is going to be in the question. You're not supposed to have palpitations in just anxiety, right? So really make sure you understand that some symptoms that pop up in these anxiety spectrum disorders are going to be very, very somatic, and it's going to be rather difficult, to be honest, to be able to actually pick the correct answer. So when you see it in your answer choice that it says hyperthyroidism, and they didn't even put it directly, it literally just said anxiety due to a general medical condition. So when you think of that, you had to kind of, if it rang in your mind that she might have hyperthyroidism, you would think of that and you would pick it. All right. Panic disorder is another issue where that becomes really, really apparent, right? So here they tell you recurrent panic attacks involving intense fear and discomfort, plus or minus unknown trigger. Attacks typically peak in 10 minutes with 4 or more of the following: palpitations, paresthesias, depersonalization or derealization, and abdominal distress or nausea, as well as intense fear of dying, intense fear of losing control or going crazy, lightheadedness, chest pain, chills, choking, sweating, shaking, shortness, okay, breath. All of these symptoms can mimic so many other things, right? Arrhythmias, heart failure, having the flu, any of that. It's really, really not easy to pick if a person has panic disorder or not. There's a strong genetic component, and there's a very high risk of suicide. which makes panic disorder something you really have to work with if a patient comes in talking about it. Diagnosis requires attack followed by 1 or more months of one or more of the following. So any attack, any panic attack has to have at least one of these things later on. Persistent concern of additional attacks, worrying about consequences of an attack, and behavioral changes related to the thought of having an attack. Okay? So if I'm that worried about my panic attacks and I'm doing something about it and I'm trying to make sure another panic attack doesn't happen, stuff like that, that is going to be in the question, and it'll really help you pick panic disorder over something else like cardiac issues, stuff like the stuff I have up here. See, in the ER, in the emergency room, these patients will often present with symptoms that resemble neurologic issues like headache, dizziness, shaking, chills, paresthesias, GIT issues like epigastric pain and nausea, cardiac issues, right, the arrhythmia, chest pain, intense sweating, or even respiratory issues, right? You might think it's pulmonary hypertension because of the shortness of breath, the choking, any of these things. So you really have to be good at making sure you can see something else, and that's these things. These 3 bullet points are the things that really help you come to the final diagnosis without a mistake. Right? There's no mistake about it. If the question mentions something like, I'm always worried my next attack is going to be coming soon, just so I'm ready for my attacks, I also carry X, Y, and Z with me. Silly things like that, which are very important for them. I called it a silly thing because it's going to be, in the question, but it's not a silly thing at all. It's just you're going to be looking for those kinds of things in the question. All right. Symptoms are the systemic manifestation of fear, which is a very powerful tool and always used to control people. Treatment involves these medications, so there's going to be venlafaxine. Always remember venlafaxine, right? Because they don't put SSRIs as an acid choice anymore. Mainly because it's too easy, right? SSRIs you will see for depression. Venlafaxine is a medication people tend to forget. So venlafaxine is one of the first-line medications for panic disorder. And here's a question about a patient with panic disorder that a lot of people were confused about. This is from UWorld too. So it says, a 32-year-old woman comes to the office due to excess anxiety and stress. The patient has been under a lot of job-related stress and has been working long hours. She says, the worst part is that I get really nervous all of a sudden and then feel shaky, dizzy, and nauseated and start to sweat. It happened while I spoke to my boss the other day, and I had to excuse myself. She's worried of having an episode during a work meeting, although it has also occurred while she was relaxing at home. She says, I avoid going out with my friends because I never know when I'm going to feel this way. Her blood pressure is normal, pulse is fine, respiratory rate is fine, physical exam and labs are also normal. What is her diagnosis? Well, it's panic disorder. She's actually doing 2 of these things. One, she's always worried. She has persistent concern of additional attacks, right? She says she's worried she's going to get an attack in her next work meeting. That's one thing. She's also having behavioral changes related to attacks. She doesn't go out anymore. I avoid going out because I might... To correct the sentence, it basically says I avoid going out with my friends because I never know when I'm going to get another panic attack. Okay, so she's doing these things. These 3 bullet points are what make the answer panic disorder. All right, some people chose acute stress disorder, and many people chose general anxiety disorder. A key feature is that at least some attacks are spontaneous with no obvious trigger, such as while relaxing. That's another thing you want to watch out for. Okay. She told you in this question that it happened while I spoke to my boss and I had to excuse myself. Where's it has also occurred right here. Although it has also occurred while she was relaxing at home. It is a panic attack. Okay, so panic attacks, they're not always related to a trigger. So if you're having a panic attack with no known trigger all of a sudden while you're just relaxing at home, and on top of that, everything else is normal, blood pressure, respiratory rate, physical exam, labs, that's panic disorder, and you just go with it. Right over here, they wrote, what are the 2 general diagnostic requirements for panic disorder? This is coming from USMLE RX. They wrote that at least 1 panic attack has to occur, obviously, right? So it might also have somatic symptoms, and there's always going to be a feeling of impending doom, and at least 1 month of preoccupation with panic attacks, which is these 3 bullet points. Okay. This is their way of describing the diagnostic requirements for panic disorder. But all in all, just look out for a patient who's having all these mix of symptoms that look very somatic, look like they're related to one of these things, some kind of system disorder, but it's also happening when the patient is resting and the patient is making lifestyle changes and consistently worried, right? These 3 bullet points. These 3 bullet points are the main diagnostic features. I like the way the first aid breaks it down. Remember that these patients will hyperventilate. Remember acid-base physiology? Leading to a loss of PCO2, causing respiratory alkalosis, right? So that's another key point to always keep in mind when you get a question about panic disorder. Right? Acid-base physiology is a really big topic. It's something I plan to make a separate video on alone, but I'll talk about it when I do renal, and that acid-base physiology video will be a separate video during renal, because that's actually a really, really big topic and very high yield everywhere. NBME at least has 6 to 7 acid-based physio questions each NBME, and they're not questions you need to get wrong. You can totally, deduce what's happening with each patient just based off of what they're presenting with. Alright, so I'm just going to stop here for now, and then in the next video we'll go on to look at the rest of your anxiety spectrum disorders. Okay, but this video is very critical because I really wanted to make sure I showed this timeline thing. I'm going to try to get some questions over here and work them out with you guys using the timeline thing, where for our thing, I'm going to put it here so I remember. For our thing, the legend is going to be circle is for psychosis, triangle is for mood, and it's going to be up or down based off the direction of the triangle. Okay, so we can use timelines like this when tackling psychiatry questions to really be able to see the answer rather than having to think about it and then trying to figure out between various answer choices, right? Because what you see on the timeline pretty much defines an answer. That's what this image is doing for you. All right, so we're gonna practice that later on. I'll put some more questions right here. I'll try to get that ready today so I can do it tomorrow. And then tomorrow we'll continue on and we'll look at the rest of these anxiety spectrum disorders and just wrap up psychiatry path so that we can start going into the farm section. Right, so there's a lot to talk about, but it's not that. Oh, actually, we won't be able to wrap it up. This is a really big part here too. So I'll go up to here because this is really important. I really want to do this very soon too, where we can talk about the various differences between these presentations and understand how to tackle them. All right, so a lot coming up. Just be ready. Every day at noon, I'll come live, and then the video's up later as well. But if you're joining the live sessions, that's great because you can ask any questions you have, whatever you want to ask. Don't hold it back. But yeah, thank you very much for joining, and I'll see you guys again later.